Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. The cardiology seminars are brought to you by Triple N Media, and our YouTube channel has more than 200 cardiology lectures. We welcome you to watch these videos for free. I also kindly request you to subscribe to our YouTube channel. If you would like to get a copy of my cardiology rotations manual, which has more than 175 pages of pertinent information to enhance your learning experience on your cardiology rotations, I will tell you how you can get a free copy of this book at the end of this presentation. The feature presentation is heart, inspection, palpation, auscultation, percussion. So we're going to be focusing predominantly on the chest. I have done a separate video on jugular venous pulse. I have done a separate video on arterial pulse. Please watch those. So the focus in this presentation is going to be on chest examination, heart and lungs. There are a lot of clues we can pick up by just observing the patient's chest, both in the front and in the back. We have to be like a private detective. We carefully scan their entire chest for any clues that may be left behind. For example, maybe a sternal incision, a pacemaker incision, anything that can tell us where the patient has been. Might give a clue in terms of inner workings of the heart. Here are some examples. As we can see, we have a pectus excavatum where these patients can have compression of the heart. They can have clicks, murmurs, and they may also have cardiovascular symptoms. If you are looking at a patient with a chronic COPD, they may have what looks like a barrel chest, like the whole chest is projecting to the front, like a barrel-shaped chest. If the patient has a history of coronary artery bypass surgery, you may be able to recognize the presence of a midline scar that suggests this patient had coronary artery bypass surgery. In fact, one of my patients, after he had a coronary artery bypass surgery, went and got a tattoo all the way across the mid-sternal area, what looked like a zipper. I said, "What's this?" He said, "Well, I've been zipped by you and the surgeon." So whatever his fancy is. Here is a clue that this patient has a pacemaker. So if this patient has a pacemaker, it is already telling us this patient has organic heart disease, has disturbances with his conduction systems, or this patient may have congestive heart failure leading to pacemaker or even a defibrillator. So all these things gives us clue, and we need to really dwell into when we see any particular clue. Tell us more about this. If the patient had a bypass surgery, ask him, when did he have the surgery? How many bypasses were done? What arteries were bypassed? Who was the surgeon? What was the hospital? And did he have stents before that? Or did he have stents after the surgery? So the whole story begins to unfold the moment you get some of these clues. The next step is palpation. We can palpate the entire chest for all kinds of interesting findings. Basically, we look for the apical impulse. We place the patient in 30-degree left lateral decubitus position and place our entire palm over the chest wall. So we can feel the entire precordial movement of the heart. If the patient has a cardiac enlargement, you can feel the heave, the heart chest wall being pushed with each contraction. You can also feel the apical impulse. The apical impulse is usually felt in the fifth intercostal space in the mid-clavicular line. If the apical impulse is displaced all the way to the anterior or mid-axillary line and down to the sixth interspace, you know you're dealing with a congestive cardiomyopathy patient or a patient with renal failure who is on dialysis, who has advanced heart failure. So just by palpating the patient, you can almost try to figure out what's going on inside the patient even before looking into anything more. Sometimes you may be able to feel other kinds of findings. For example, if the patient has pulmonary hypertension or significantly elevated right heart pressure or tricuspid regurg, we may be able to feel a precordial lift here. Same way at the apex, if you have a left ventricular enlargement or left ventricular hypertrophy, we can feel a heaving apical impulse. If a patient has a significant aortic stenosis, we may be even able to feel a trill in the right second intercostal space, and you may be even able to hear without a stethoscope sound when a patient has a critical aortic stenosis. Some of these things will really bring you into the entire history of this patient. The next step is cardiac auscultation. Of course, in order to listen to the heart, we have to place the patient on the left side 30 degrees, have the patient lift the arm and put it underneath the head. You kind of take the arm away from this one so that the chest wall opens, the heart comes close to the chest wall, so you will be able to hear the sounds better. First, listen to the apex, then we focus on the heart sounds. We have the first heart sound, which is caused by the closure of the mitral and the tricuspid valve. The second heart sound is relating to the closure of the aortic and pulmonic valves. The third heart sound is the rapid ventricular filling, heard commonly in young children or in patients with left ventricular failure. The fourth heart sound is the atrial sound, that is working against a non-compliant ventricle of patients with elevated end diastolic pressure, and that is heard before the first heart sound. Actually, the normal heart sounds would sound like whereas if we have a S3 gallop, it's going to sound like. The S3 comes right after the second sound, so it's closer to the second sound. That's why you get. Whereas S4 is just before the first heart sound or before the ventricular systole, so you may hear. As far as the heart sounds are concerned, there's a whole chapter on heart murmurs. In the next presentation, I'm going to talk about all the various kinds of heart murmurs that we can hear by auscultation of the chest. But first, let us focus upon what we need to do on a everyday routine exam if the patient doesn't have valvular heart disease or significant murmurs. So we listen to the heart sounds. We listen to the splitting of the sounds. The splitting of the sounds itself is a whole chapter by itself. Of course, when we listen to the murmurs, we want to see if the murmur is radiating to other parts of the body. For example, a patient with a mitral regurgitation, the murmur may be heard best at the apex, and it may also radiate to the left axilla. And if you listen to the whole systolic murmur like even the second sound is sort of muffled because the whole systolic murmur goes beyond the second sound. This mitral regurg murmur may radiate to the axilla, whereas the aortic murmur, which is heard, it is a crescendo, decrescendo murmur, and it can radiate to the neck, whereas the tricuspid regurg murmur radiates to it's best heard in the left sternal border. Then we look for the murmurs, the systolic murmurs or the diastolic murmurs. Also look for rupts. If a patient has pericarditis, we may be able to hear rupts. Sometimes we may be in constrictive pericarditis, we may be able to hear knocks. If a patient has mitral stenosis, we can hear some snaps or clicks. Like in patients with aortic stenosis, you get an ejection click. In mitral valve prolapse, you get a mid-systolic click. So there are a lot of things that we can hear. And also remember, we could hear the prosthetic valves clicks. As a matter of fact, by just listening to the patient's chest without putting any stethoscope on the chest, if you hear a click, then you know this patient had a mechanical valve replacement in the past. So it opens up a whole story about his journey going through heart valve problem and getting a mechanical valve. And when you listen to the chest, you should be able to hear a mechanical valve sound. If you don't hear you and the patient both are in trouble. That means you got an emergency. You need to get a stat echo and see why you're not hearing the prosthetic valve sounds, especially the mechanical valve sounds. Where do we focus on for different kinds of murmurs? This is an important topic. If we are dealing with a mitral valve disease like mitral stenosis, mitral regurgitation, or mitral valve prolapse, you listen to them on the mitral area, which is basically the apex of the heart, which is in the mid-clavicular line in the fifth intercostal space. You put the patient 30 degrees lateral decubitus position and you lightly press the diaphragm and you listen to that. You can hear the systolic murmurs, you can hear the opening snap, you can hear the mid-diastolic rumble, and then you can also hear the S4 sound, which is the atrial kick. If you are looking for a pulmonary hypertension or a tricuspid regurgitation, you put the diaphragm here on the right sternal border and you'll be able to hear the holosystolic murmur related to the tricuspid valve regurgitation. If we are dealing with aortic stenosis or aortic regurgitation, then we place the diaphragm here in the second intercostal space to the right of the sternum. When we are listening to the aortic valve, we want the patient to be sitting up and leaning forwards and have the patient exhale and hold the breath so that all the structures come close to the chest wall. Here you're not only going to hear the systolic murmur of aortic stenosis, which is a crescendo, decrescendo murmur. It may also radiate to the carotids. When it radiates to the carotids, you want to make sure you listen to the carotids and they don't have like carotid artery stenosis. Sometimes it may be difficult to differentiate, but aortic murmur not only radiates to the neck, it can also radiate to the apex. So the aortic murmur may be sometimes heard loudest even at the left ventricular apex. If you are dealing with a patient with pulmonary hypertension who has elevated pulmonary artery and right ventricular pressure, then you're going to hear a murmur in the left second intercostal space, and this murmur may change with respirations. So those are the four main areas as far as cardiac auscultation are concerned. But a cardiologist's job doesn't end with just auscultation of the heart, because there are a lot of things that happen in the heart that directly or indirectly affect the lungs. So listening to the heart and ignoring the lungs is a major crime. Before I go into, I want to tell you the first heart sound is made up of the mitral and the tricuspid valve closures. The mitral valve comes in first and the tricuspid valve next, whereas the second heart sound is created by the closure of the aortic and the pulmonic valve. The aortic valve closes first and the pulmonic valve closes second. Now we need to listen to the chest. Yes, we need to listen to the chest because whatever is happening on the left side of the heart may be reflected onto the lungs in terms of rales, rhonchi, wheezing, tubular breath sounds, crackles. There may be fluid collection with absent breath sounds. So all these things sort of give a clue as to what's happening not only to the heart, but its effects on the lungs in terms of pulmonary congestion, pleural effusions, or atelectasis or infiltrates. In the next presentation, I'm going to talk exclusively about heart murmurs. Ladies and gentlemen, this cardiology seminar has been brought to you by NNN Media on our YouTube channel. We have more than 200 lectures. Please feel free to watch them. And if you would like to get a copy of this cardiology rotations manual, please send me an email to drniknikam@gmail.com. I'll be happy to send you a free copy. And this is NNN Media. This is going to be my next presentation. Please do subscribe to my YouTube channel, and I will see you in the next presentation when I'm going to talk about heart murmurs.